what were the guiding principles of making changes for the DSM-5? On one hand, there should be research evidence to support any of the modifications. Secondly, if possible, there should be continuity with the current DSM so that there isn't an abrupt shift all of a sudden in the way everybody's diagnosing. But having said that, they also said that that continuity alone was not reason to keep something if research supported that it should be changed. And it should be able to be implemented in routine practice. So we'll see how well they did on all of these things. So there are a number of different kinds of changes, and I'm going to be spending the next number of slides just looking at what the structural changes are. Because as Diane talked about, we started to immerse ourselves in this, and we thought, I think, that we were going to be looking at, okay, what are the new criteria for this, and what are the new criteria for that? And instead we're looking at, where is it? It's like, where's Waldo? What have they done with? And then you flip through. So there are structural changes, and your handout simply is a list of the overall structure of the DSM, and you can compare the chapters in DSM-4 TR and the chapters in DSM-5. So as we go through, it's helpful, I think, to have that in front of you. There are shifting criteria. Some things have new criteria, some things have different criteria. There are some new diagnoses that we have not seen before. There are some reclassification of diagnoses. So they've been moved. If it's a wine glass, now instead of thinking of it as a drinking implement, it's now next to the wine and is thought of as barware. So we're going to see a lot of that. And there are a few deleted diagnoses, and all the code numbers are changed. So it's, if you've memorized all the code numbers, throw those out. But this is done to be more in keeping with ICD, which was long a goal of DSM, but they never fully realized it before. So there are 3 sections to the DSM-5. The first section is the introduction, how to use it, all that front page material. The second section are the 20 chapters, so that's increased from the previous book. And then the third section is conditions requiring further research, cultural formulations, and glossary. And I'm going to say, as we go through, we'll try to tell you some of the things that didn't quite make it into the main section that did go into section 3 for further research. And I'm going to say more about culture as well. So the order of the chapters is changed. If you look at your DSM-4, can anyone tell me in what order are the chapters in DSM-4?
It'll make no sense.
That would have been my answer. They make no sense. But in fact, they're theoretically in order of frequency at which they appear in hospitals. Now, knowing that doesn't help you either, does it? It doesn't mean, okay, let me go look up dementia. Now, how frequent is dementia in hospitals? The DSM-5 has reordered a number of things, and there were changes happening to the DSM-5 all the way until the vote got taken last December. So when we started trying to learn about this, we learned some things that then turned out to have been reversed. So I have heard 2 versions of the order for DSM-5. One version is it's in order of age at which it tends to occur, which if you look starts to make sense because we have the neurodevelopmental orders early, we have dementia late, but then if you look in between it makes no sense. And it also might be in terms of relatedness, so related chapters go together. I don't know that we're going to see much more of a logic that's going to make it easier to find things in DSM-5 than we did in 4. Another major change is there are no axes. When you give a diagnosis, you're going to give a diagnosis and you're not going to worry about what axis it went on. That had been a pretty major change before, going from no axes to 5 axes. And so now they've moved back to no axes. And the question is, what have they done with the information that was on the axes? So I want to address that in a few minutes as well. And for each of the diagnoses, you're going to be noting the degree of insight that the person has. There's going to be specifiers for insight level. Good to fair, meaning it's dystonic, the disorder is dystonic. Poor insight, sort of ambivalent about your disorder. Or absent insight, which is the disorder is syntonic. There are going to be some diagnoses that require you to have direct knowledge of the patient over a 12-month period, where you have to directly observe the symptoms in your office, in the relationship with you, maybe in another setting, hear self-reports, etc. That's very different. You're going to be giving severity indices, which is in essence replacing axis 5 of the GAF. It's no longer called the GAF, it's now a severity scale. So for every diagnosis, you're going to be giving a number, and just in case that was too simple, some of the diagnoses have severities that go up to level 2, and other diagnoses have severity levels that go up to number 3. Okay? In addition, some diagnoses, you not only have to give an overall severity level, but for each of the symptoms, you're going to be giving a severity level. So if, for example, when we get to autism spectrum disorders, you have to have 5 out of 7 symptoms. For each of those 5 symptoms that are positive, you give a severity level. No problem. And remember, the language in DSM-4 was always caused objective impairment or distress. The new language is over time and circumstances. Symptoms are seen over time and circumstances. That's going to be emphasized throughout the DSM-5. So what happened to axis 3? It's going to be part of the specifiers for whatever your diagnosis is. Axis 4, you're going to make notations, I'm not sure exactly where, but notations will go somewhere about the psychosocial and contextual factors, but there's no specific axis for that. And when DSM-4 came out, they made a big deal about always ruling out 4 diagnoses before you ever looked at anything more specific. And the big 4 were general medical condition, substance use or abuse or dependence, malingering or factitious, or, surprise, surprise, normal. What'd they do with those? Well, the general medical condition is going to become a part of the diagnosis itself. So that'll be on your diagnostic label. Substance abuse is now, throughout the DSM, going to be noted for its correlation with specific diagnoses. So if, for example, you look up panic disorder, in the text it will give you information about whether panic disorder is correlated in general with substance use. So they are now giving you information for each disorder. What that suggests, however, is that in your notes, if you've noted a disorder that in the DSM is noted to be correlated, you better have something about having asked about that, or it looks negligent. They also are going to note the correlation with suicide, and again, it's going to be very important for clinicians to document that they've asked about this. If the DSM said to you, this is correlated with suicide, and you have nowhere that you've asked about it, it didn't happen. So that's going to be very important for people to know. And then malingering, it's really interesting because they made such a point of this before. Malingering was in the DSM-3. It was barely changed in the DSM-4, and it's hardly changed at all in the DSM-5, which means that it hasn't changed very much in 30 years, despite the fact that there's over 1,200 articles on malingering. So this is one area, you know, diagnoses go in and out of favor, and this is one that just sort of dropped out of sight and doesn't seem to be as emphasized as it had been in the past. We're all used to the NOS, not otherwise specified diagnosis, which, as Diane was saying, seems to be one of our favorite diagnoses. And the new language is conditions not elsewhere classified. CNEC, and I always feel like the village people, CNEC. So you're going to want to take note of that. However, because they are interested in reducing this diagnostic uncertainty and waffling with the NOS, you can only give CNEC for 6 months. What does this mean? If somebody is subclinical, so you've given a CNEC, and then you can't give it anymore after 6 months. The problems haven't disappeared, the person hasn't disappeared, but you now don't know what to give them. And what does that mean in terms of insurance reimbursement? So there's a lot of questions about the CNEC. And you're only supposed to give it for very specific reasons. They've really backed off from the idea of diagnostic uncertainty. So you're only supposed to give it if the diagnosis is unclear, you're not trained to make the diagnosis, you can't get any information out of the client because maybe they're inebriated, maybe they have dementia, maybe they're just uncooperative, or you don't have the records, you can't get enough information for whatever reason, or you need or are required to take more time in order to make the diagnosis. So this is not really equivalent to NOS because it can't remain the diagnosis. This language of over time and circumstances is to reduce overdiagnosis, and you'll see the language very specifically for specific disorders where it was felt that especially children were being overdiagnosed with something. You will note the correlation to substance abuse, as I said earlier, and the correlation to suicide. And then I'm going to be talking about these 5 pathogenic realms, which I will explain what those are in a little bit, because there is now a bit of a throwback to DSM-2. DSM-2 had hypothetical causes of disorders, and they were psychodynamic causes. Well, DSM-5 also has some organization by cause, only now the causes are what shows on a PET scan or a CAT scan. So things are reorganized for biochemical reasons in a way that previously they were organized by theory. So the 5 pathogenic realms is going to refer to particular disorders that are thought to occur because of the environment, which makes them distinct from disorders which are thought to be neurodevelopmental. So this will become clearer as I go into those disorders. Lest you think I'm all negative, there are some positives here. It should be more reliable. If it is more reliable, there'll be better treatment planning, more correlation. Anytime they have ever done a study where they go back to do re-diagnosis using RDC criteria, research diagnostic criteria, they find enormous rates of misdiagnosis. So hopefully the DSM-5 will start to address some of that. It will be more reliable, so there might be better treatment planning, and possibly slightly longer times will be authorized by insurance for reimbursement. However, this is definitely going to take more work on the part of the clinician. There are a lot of rating scales for a lot of the different disorders. So if you have to give 3 out of 5 positive symptoms, you might have a rating scale for each of those 3 symptoms. You actually might have a rating scale for all 5 of them, and then you show elevated on 3 of them and not elevated on 2. So the diagnostic process is going to be slowed down and take more work. There's also probably going to be much more demand for outcome studies. If there's going to be more reliable diagnosis, there's going to be a push towards one diagnosis, one treatment correlation, probably. And in fact, the Department of Corrections is already moving in this direction. I suspect the VA is not far behind. So you have a lot more responsibilities for showing things like severity and the symptom scales for different disorders. As we talked about, there is a new order. Some of the chapters have been split, so when you're used to seeing things together, they now might be in different places. We're going to see, for example, the anxiety disorders. There are now 3 chapters covering what used to be 1 chapter of anxiety disorders. We're going to see some renaming, so the neurodevelopmental disorders are new. You are no longer going to find a chapter called disorders usually first observed in infancy, childhood, or adolescence. So you're going to be looking throughout the DSM-5 for those disorders. And then we're going to have some new chapters like trauma and stressor-related disorders. And I simply have here a list of the different disorders, of the chapters, but you also have that in your handout. That was just the preamble. We haven't even gotten to the amble.